You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology. And this is This Week in Cardiology for November 14th, 2025. This week, I'll do some listener feedback on that remarkable PISCES trial last week, American Heart Association meeting news, including a big PCSK9 inhibitor trial, beta blocker, post-MI, left atrial appendage closure, and post-AF ablation anticoagulation use. First, some listener feedback on the PISCES trial. This was fish oil in patients on hemodialysis, and it found a clinically meaningful, statistically robust 43% reduction in a MACE endpoint over a corn oil placebo. All components of the endpoint were reduced, including cardiac death. I hemmed and hawed on this, and I scratched my head because, come on, I thought. We aren't sure fish oil works in the general population, and we know nothing works in hemodialysis patients, not statins, not MRAs, not ICDs. How can we expect fish pills to shred CV outcomes in patients on hemodialysis? But the PISCES data are remarkable, and we don't have any other data coming, so I leaned on saying I would accept the trial results, and if it were me, I would prescribe hemodialysis patients these fish pills because there's little downside. But I received an excellent critical appraisal from Dr. Richard Bogle from London. He makes 4 points, and it's really a tour de force of learning, so I'm going to share it with you. Dr. Bogle writes that the primary endpoint rate ratio of 0.57 is a huge relative risk reduction in serious cardiovascular events with a rate difference of 0.61 down to 0.31 per 1,000 patient days. This translates to an absolute risk reduction of about 0.3 to 1,000 patient days, so over 3.5 years, there would be 110 to 120 events prevented per 1,000 patients, which is staggering, and when something seems too good to be true, then it probably is, especially in a population whose CV risk is multifactorial and dominated by calcific arteriopathy and sudden death. He then goes on to say, I think we need to look at the composite, which included serious CV events, which were broad and unusually included PVD leading to amputation. So Bogle says that all these components numerically favored fish oil, but there's something methodologically suspicious, so that is the relative risk reduction is almost uniform across all these different pathophysiologic distinct outcomes. Atherothrombosis, arrhythmia, cerebrovascular, peripheral ischemia. This suggests to him either a strong unmeasured bias or an artifact of composite counting. It's biologically implausible for omega-3s to have risk across all these processes simultaneously. The next problem he notes is that death from any cause had a hazard ratio of 0.89, 0.73 to 1.01. It was not significant. So despite having cardiac deaths, the total mortality barely moved. That can't be reconciled mechanistically unless non-CV deaths rose proportionally, for instance, infection or malignancy. And he feels like this undermines the plausibility of the primary finding since you can't reduce cardiac death by half and then have all-cause mortality unchanged unless classification is unstable. This implies cause of death attribution may have been loose or the adjudication relied on clinical judgment without autopsy or ECG correlation. Finally, he writes, the primary endpoint events, 158 versus 309, is also a problem. Multiple recurrent events are possible per patient. Now, they mention a Williams-Peterson gap time model, which is event-based, not patient-based. If the same high-risk individuals contributed several events, an apparent doubling in the placebo arm can emerge from event clustering rather than genuine incidence difference. And he notes that when you look at their first event analysis per person, which they do show, then the numbers look more sensible. Here it's 215 versus 270. That hazard ratio is 0.73. So I think the main reported of 0.57 hazard ratio probably overstates benefit, and the first event analysis, 0.73, which is a 27% relative risk reduction, appears to be more reasonable. And then he concludes with the obvious sentence that I'd love to believe that simply prescribing fish oil to people with end-stage renal disease would have such a beneficial effect, but I remain skeptical at this moment. Fine, these are great comments, but I would still add that we don't have any other data, and fish pills don't seem to have much downside. Next topic is PCSK9 inhibitor news. At AHA, we heard results of the Basilius trial with avelocimab in patients with established atherosclerotic vascular disease, but without a previous MI or stroke. Now, this was billed as a primary prevention study, but I'm not sure that it is correct because 2/3 of the patients had documented atherosclerosis, about half with CAD. The two previous PCSK9 trials, Fourier with avelocimab, enrolled patients with documented disease defined by a history of MI, stroke, or PAD, and Odyssey with alirocumab enrolled patients after an MI. These were clearly secondary prevention trials, and they enrolled 27,000 and 18,000 patients respectively. In Vesalius, approximately 12,000 patients, 12,000 with atherosclerotic vascular disease or diabetes without a previous MI and an LDL cholesterol greater than 90 milligrams per deciliter were randomly assigned to avelocimab or placebo. This trial had two primary endpoints: a 3-point MACE of coronary heart disease death, MI, or stroke, and then the 4-point MACE was the same as the 3-point added ischemia-driven revascularization. These were 66-year-old patients, 43% women. The median follow-up pretty good at 4.6 years, and the 3-point MACE, which I'll sort of lean on, is 6.2% versus 8.0%. Hazard ratio in favor of avelocimab 0.75, and the confidence interval is pretty tight at 0.65 to 0.86, which was highly statistically significant. The 4-point MACE was also positive as well. The absolute risk reduction for the 3-point MACE was 1.8%. That's an NNT of 55. The components of the primary endpoint, MI, was 46% lower. That was the driver. Coronary heart disease deaths was 11% lower. That was not significant. Stroke was 21% lower, not significant. Quote, given that avelocimab therapy had no significant effect on death from coronary heart disease, results for the remaining secondary endpoints in the testing hierarchy should be considered exploratory. In other words, CV death, which was 2.8 versus 3.6%, it was 21% lower, but the New England Journal doesn't report a p-value. All-cause death was also 20% lower, but there's no reported p-value because you can't really test those because there's not enough alpha. So my comments. Okay, the first thing to say is that this was hardly a primary prevention study. The majority of patients had atherosclerotic disease, and coronary death rates were similar in this trial as they were in the Odyssey post-MI study. So these were not 45-year-old people with high cholesterol and mild hypertension. This is likely the reason that New England Journal of Medicine wrote to conclusion with these words, quote, among patients without a history of MI or stroke. They didn't say among primary prevention patients. So the second thing to say is that this was a positive trial. The absolute risk reduction of 1.8% in the first primary is reasonably clinically significant. The NNT is 55, though much of the effect was in non-fatal MI. So in a trial with 12,000 pretty high-risk patients, there were about 80 fewer non-fatal MIs in the avelocimab group. So that 46% reduction was not enough to make coronary death lower, however. Okay, so the third thing to say was that patients were at least 87% of patients were on a statin, 20% on ezetimibe. The mean LDL cholesterol in these drugs was 122 milligrams per deciliter. So these are patients with pretty high LDLs despite therapy. So is this trial a win? Well, I'd say it's a small win. And that means considering the effect size divided by the cost. Now, I've read that the cost of PCSK9 inhibitors is coming down, but whatever it is, it's still pretty pricey for most regular people. So people have to decide if that reduction of events is worth it. The fourth thing to say about this data is a mechanistic comment. That is, that here is another study that absolutely 100% proves that LDL cholesterol is causal in the atherosclerotic process. There are people who happen to be prominent online who propose that LDL is not causal. Well, here, LDL on therapy goes to like 40 milligrams per deciliter, and to me, this about proves the causal nature of LDL cholesterol, if you even needed more proof. But the caveat here, and I think it's best outlined by my friend Dr. Anish Koka on Twitter, and I'll link to his Twitter post, is that LDL cholesterol is but one causal pathway to coronary heart disease. Anish writes that the message to me is that the LDL story is low yield as a target for reduction once you've already achieved a relatively low LDL. If we want to establish or massively reduce coronary heart disease, then we need to find other targets that are higher yield. So it's hard to argue with the floor effect on lipid lowering. I realize that the lipid biotech space is on fire. I mean, people are working on all different kinds of targets. They're even working on gene editing for permanent reduction of LDL cholesterol. But the one thing that I would add to Anish's comment, which maybe you would find controversial, is that abolishing coronary heart disease will never happen. Never. I believe the human species is inexorably linked to coronary death. Think about it. If we prevent a 66-year-old from dying of a coronary death, what happens when they're 70 or 80 or 90? It's not like they live forever. They get coronary disease. Now, don't mistake anything I'm saying. I think it's good to prolong life free of MI, but I don't ever see humans without coronary death. Yet we have come so far, right? Prevention is better, but so is treatment in the cath lab. And the better we get with stent technology and the like, the less important prevention becomes. I mean, perhaps the reason you get a 46% lower rate of MI with evolocumab, but no real difference in coronary death, is because MI care is so good. I mean, the frontier of coronary disease therapy, both prevention and intervention, I think, is at a plateau. And the plateau is fine. We're good. We can take our LDL cholesterol lowering drugs and we can live our life. If we don't ignore early symptoms like chest pain, we should do well. If we have an MI, chances are that will go well too. I think the biggest danger we face now in 2025 is actually hype. For instance, Medicare will now cover $1,000 AI heart scans. Now, I may be wrong, but I can find no outcome trials with these FFR CTs. And we know that regular FFR got started with the FAME2 trial, and FAME2 is completely biased, right? It's all faith healing and subtraction anxiety. So I would say beware of the imagers. Until the imagers bring outcomes, I remain skeptical and I remain worried about hype in this space going forward. Okay, the next topic is beta blockers after MI and Professor John Cleland at the American Heart and published in New England is the least surprising meta-analysis ever published. You recall from just a few months ago in Madrid, we learned results of 2 beta blocker trials, the Spanish Reboot CNIC trial with 8,400 patients with MI and LVF greater than 40%. The primary endpoint of death, MI, heart failure, occurred in 22.5 versus 21.7%, so no difference. The primary beta blocker was bisoprolol. And then the second trial was the Betami-Danblock trial. This was a combined Norwegian-Danish trial of 5,500 patients with MI and EF greater than 40%. The primary endpoint of death, MI, unplanned revasc, stroke, heart failure, VT, was 14.2% versus 16.3%, so actually was lower with the beta blocker, driven mainly by a reduced MI risk. And of course, we also have the previous beta blocker trials that I've written about before, Reduce AMI, published in April 2024. This was a Swedish trial, 5,000 patients with preserved EF post-MI. The primary endpoint was death or MI, and it was 7.9 versus 8.3%, so no difference. And then, of course, there was the Abyss trial. This was August 2024. This was about 3,700 French patients with prior MI, out 6 months, EF greater than 40%, or randomized to continue or stop beta blockers at 6 months. In ABYSS, the primary endpoint of death, MI, stroke, or cardiac hospitalization was 23.8% in the interruption group versus 21.1% in the continuation, and that hazard ratio of 1.16 was significant. However, when you look at the endpoints, death, MI, and stroke were absolutely not different, so it was all driven by hospitalization. Of course, this was an open-label trial. So my feeling about ABYSS is it's exactly the same as all the other non-significant beta blocker trials. And finally, there was a capital RCT. This was a smaller RCT in Japan with carvedilol, and again, no difference in the primary endpoint of MACE. Notable here was that this meta-analysis of 17,800 post-MI patients in these trials included only the ones with normal EF. In Lancet, at the ESC, these authors published a patient-level meta-analysis of patients from the trials who had an EF of 40 to 50%. The first author of that paper was Rosello, and it had only 1,800 patients, so a much smaller fraction. The primary outcome of death, MI, or heart failure occurred 25% less often in the beta blocker arm, hazard ratio 0.75, but the confidence intervals went from 0.58 to 0.97, so it got awfully close to 1.0. I wasn't that impressed with this meta-analysis because the driver, again, was MI, not death or heart failure. The absolute risk reduction was small, and the findings were quite fragile statistically, and moreover, I don't see that much precision in echo reading of left ventricular ejection fraction. For instance, are you telling me that a beta blocker is beneficial when the EF is 48%, but not beneficial when it's 52%? But no matter, this meta-analysis in New England was the larger block of patients with normal EF, and the results are super easy to explain. The tiny reduction in MI that was seen in the Batami-Dan block trial was easily overshadowed by the other non-significant trials, and the summary statistic between beta blocker and no beta blocker was nearly 1.0. Absolutely no difference. The 95% confidence intervals were tight. They went from 0.87 to 1.07. So I think with pretty good certainty we can say that in these patients, like those in the trial, there was absolutely no difference. Now, my comments overall, I am not sure we needed this meta-analysis. I mean, why bother combining this many negative trials? To me, the conclusion that in patients like those in the trials, there's no reason to routinely use beta blockers for cardiac protection. We could have gathered that from the trials. But I do think that these quality measures that penalize people for not using beta blocker in every patient with MI should go away. Guidelines need to change. Beta blockers may be fine to use post-MI. You could have a patient with hypertension or palpitations or PVCs or AFib, or you're just worried about their MI for a few days or weeks. But if a person comes in with STEMI, they have a rapid PCI and a stent, and the echo the next day is normal, it's hard for me to believe there is benefit. But, and I can't believe there is a but here, but there is. One of the smartest minds in all of cardiology today, Professor John Cleland from Glasgow, Scotland, has penned a provocative editorial in Nature Reviews, and I'm going to link to the paper. I can't say enough positive things about Dr. Cleland. The guy is a thinker. One of the greatest compliments I ever received was that after a lecture I gave, someone said that it reminded them of John Cleland, and I thought, well, good. That's good. Anyway, in the Nature paper, Professor Cleland made 3 important points, and he came to an interesting conclusion. His first point was on external validity of these trials. They enrolled selected patients. He notes that only 5 to 10% of eligible patients participated in the trials, and those that were enrolled had exceptionally low risk. They had a 1% one-year mortality, and Cleland compares that to observational studies showing that it's 10% in typical practice. Second point is that the beta blocker choice may be important. The trials predominantly use bisoprolol and metoprolol, which lack robust evidence. Non-selective agents like propranolol, timolol, carvedilol may be the better choice because they have more proven mortality benefits. The third point he makes is that there's a vulnerable period and it may matter. Patients may be at high risk immediately post-MI. this wasn't observed in these trials because of careful patient selection, but Cleland notes that it exists in real-world practice. So I'll read you his conclusions. Quote, for patients with MI, it might be wise to initiate beta blocker therapy, preferably propranolol, timolol, or carvedilol, and other treatments routinely, then reevaluate the patient after 6 to 12 weeks with subsequent withdrawal of unnecessary treatment. This might include beta blockers, RAS inhibitors, and even antiplatelet agents. And he goes on to say, even if beta blockers do not reduce morbidity and mortality in the short term, they might reduce anxiety and stress. Moreover, many patients equate deprescribing with an improvement in their condition and will be happy to take a short course of therapy after an MI. Early withdrawal of treatment can be considered for those with adverse effects. Routine administration of beta blocker therapy in the aftermath of MI seems the best course of action for the majority of patients, with selective withdrawal being considered several weeks or months later after the vulnerable period has passed. Wow. Well, I give strong weight to Professor Cleland's ideas. External validity is always a crucial matter. Now, while there are 17,000 patients in this meta-analysis, Cleland rightly points out that it is still a highly selected bunch. I mean, most trials are highly selected, and of course, this bears on translation. What's more, the tremendously low mortality in these trials speak to the selective nature. So I really can't strongly oppose the notion of short-term use of beta blockers, especially when you feel short-term risk might be high. And deprescribing at 6 to 12 weeks is also nice, especially if the patient knows this is the plan. I'm interested in what you think. I still think, though, the quality measures saying that we should use beta blockers in every patient need to be changed. All right, third topic is left atrial appendage closure, the CLOSURE AF trial. At AHA, Professor Ulf Landmesser from Charité Hospital in Berlin presented results of the CLOSURE AF trial. This was an RCT of left atrial appendage closure percutaneous versus best medical care in patients who had AFib and were at high stroke and bleeding risk. Now, CLOSURE AF was an investigator-initiated, non-industry funded trial done in multiple centers in Germany, which, by the way, has been doing left atrial appendage closure for many years before we started in the U.S. These are experts in left atrial appendage closure. Patients in the trial were high risk, average CHA2DS2-VASc 5.2, has bled 3, age 79, exactly like patients that get left atrial appendage closure these days. And in the trial, closure could have been with a Watchman or amulet, and the majority of Watchmen were the most recent version. Best medical care was mostly DOACs, but 10% of the patients in that arm were not on any anticoagulation. Basically, it was physician's choice. The primary endpoint of CLOSURE AF was a component of stroke, systemic embolism, CV, or unexplained death, or major bleeding. Now, as I wrote in the preview, I do not love this endpoint because if CLOSURE AF was a non-inferiority design and you don't want efficacy, which are thrombotic endpoints, and safety, bleeding endpoints in the same non-inferiority endpoint because they're expected to go in opposite directions. And if they go in opposite directions, they cancel each other out, leading to no difference, which of course is a positive result in a non-inferiority trial. But actually, that's not what happened. In the 900 patients randomized, the incidence of a primary outcome in the closure arm was 16.83 per 100 patient years versus 13.27 per 100 patient years in the best medical care. That's an adjusted hazard ratio of 1.28, 28% worse in the closure arm. And the 95% confidence intervals went from 1.01, the upper bound 1.62, non-inferiority margin was 1.3 or 30% worse. So clearly the upper bound or worst case scenario was way worse than the non-inferiority margin, and it did not make non-inferiority. Now, what's more, in a non-inferiority trial, you really need to look at the per protocol, that is the patients who got the device or got the therapy, as this is a more rigorous test of non-inferiority. And here, in this trial, the per protocol was even worse, 34% higher for left atrial appendage closure. Now, as the lower bound in these were greater than 1, it allows us to conclude not only that the device was not non-inferior, but we can also say that it was inferior to best medical care. A look at the individual components of the primary outcome is revealing. Stroke and systemic embolism occurred in 30 versus 28 patients, so higher in the appendage closure arm, but very similar. Major bleeding, 70 versus 61 patients in the appendage versus medical care. So major bleeding was not lower in the appendage closure arm, it was higher. CV death, 99 versus 81, higher in the appendage closure arm. So each endpoint was worse in the closure arm. This despite very high success rates of closure, with more than 96% successfully implanted without significant peri-device leaks, except there were procedural complications. 18 patients in this trial had major bleeding requiring transfusion during the procedure or around the procedure. There was one device that went missing, embolization, one procedure-related TIA, one peripheral embolism, and 2 deaths within 7 days of the implant. So my comments. These results were presented but have not yet been published, so we wait for the paper, but I think this is strong evidence against left atrial appendage closure. It's a well-conducted, non-industry funded trial without obvious bias. It's done in Germany, a place known for expertise and early acceptance of left atrial appendage closure. You also see the importance of including peri-procedural events. As I wrote in my column, procedural risk is the Achilles heel of this strategy. Why is it? Why is it the Achilles heel? Because probabilistically, the device has to overcome the upfront risk of the procedure. So future stroke and bleeding events have to be substantially lower to overcome the initial risk a patient undertakes to having this device. In closure AF, done in experienced labs within the confines of a clinical trial where everybody's trying to do their best, this was clearly not achieved. So here's another lesson for my colleagues who think bruising or the potential for falls or a hemorrhoid bleed or even a diverticular bleed are contraindications to restarting oral anticoagulation. So notable in this trial was that an inclusion criteria to get in the trial was a major bleeding event. Now, because the paper is not published, we don't know how many people in closure AF were enrolled because of a major bleed versus just high HAS-BLED score. The point is that however many of these patients were enrolled, half were randomized to take oral anticoagulation, and that group still did better. Of course they did better. The literature is full of studies that show the feasibility and likely benefits of restarting DOACs after a bleeding episode. Now, proponents of appendage closure just simply ignore that data. Now, I've asked you all to consider a Bayesian perspective on these negative results of closure AF. Namely, what should your priors have been? Should you have been surprised at this? And I would just submit to you, like I always have, that PROTECT AF, which was Watchman versus Warfarin, was rejected by the FDA. PREVAIL, which was the second, missed its most important non-inferiority primary endpoint. It was not non-inferior. PROG 17 met non-inferiority for net adverse cardiac events, but not for ischemic outcomes. And of course, the recent option trial did not win if it used peri-procedural bleeding. Thus, our priors for appendage closure should have been extremely pessimistic, and now closure AF comes out negative, and it just strengthens our pessimism. Now, of course, I know my colleagues, my proponents for this, proponents for appendage closure will say that we have to wait for the Champion AF trial and Catalyst AF trials, and that's fine. These are bigger trials, but they're going to be industry funded and they're going to be industry controlled. I think closure AF is very strong data, and I think it heralds one of cardiology's biggest errors. If we're wrong about appendage closure, more than 500,000 patients have had this. All right, next topic is oral anticoagulation after AFib ablation. This is the OCEAN trial. Now, patients often ask if they can stop anticoagulation after AF ablation. They think clearly. Their minds are clear. They think oral anticoagulation was started because I had AF, you ablated me, I no longer have AF. Why do I need to take oral anticoagulation anymore? We've ablated AFib for 20 years, and for these 2 decades, we've gone by expert opinion, which held that anticoagulation after ablation should be guided by the CHA2DS2-VASc score, regardless of the rhythm. This has led to people without AFib taking anticoagulation for years and years. Well, at the AHA, Dr. Atul Verma, the PI of the OCEAN trial, provided some evidence in a mostly evidence-free zone. I say mostly because at ESC, we heard results of the Alone AF trial. Alone AF was an RCT of 840 South Korean patients who had successful AF ablation. And in the trial, only 1 of 417 patients who discontinued anticoagulation had a primary endpoint of stroke, systemic embolism, or bleed, versus 8 of 422 patients who continued anticoagulation. Now, this lower rate met statistical significance, barely, but the obvious thing of Alone AF was the tiny event rates. And that's exactly what we saw in OCEAN. OCEAN had 640 patients who had successful AF ablation, and patients after a year were randomized to rivaroxaban 15 milligrams or aspirin low dose. And the primary outcome of stroke, systemic embolism, or covert stroke by serial MI was 5 versus 9 patients. Now, that's a hazard ratio of 0.56, but confidence intervals go from 0.19 to 1.65, and the technical conclusion was that rivaroxaban was not superior to aspirin. Fatal or major bleeding, which was the composite primary safety outcome, occurred in 10 patients, 1.6% with rivaroxaban, 4 patients, 0.6% with aspirin. That hazard ratio, 2.5, higher in the anticoagulation arm, but again, confidence intervals go from 0.79 to 7.95 at 3 years. So this was also not significant. I wrote about the OCEAN trial in a column, and I'll link to it, and I said that the low event rates, less than 20% of what was predicted, led to wide confidence intervals and a largely uninformative comparison between rivaroxaban and aspirin. And even bleeding was so low in incidence that it didn't reach statistical significance. And this means that you cannot convert a non-significant, underpowered trial into a non-inferiority trial. In other words, it's incorrect to say that aspirin was non-inferior to rivaroxaban. It's also incorrect to say that there was no difference in the rate of events. The correct interpretation is that we don't know which arm was better. If more patients were recruited or followed for longer and we had more events, the trend of 5 versus 9 patients with stroke events might have found rivaroxaban superior. We just don't know. But I will say this, that while the drug comparison, rivaroxaban versus aspirin, was not informative, the very low stroke rates, these are very informative. The mean CHA2DS2-VASc score in OCEAN patients was only 2.2, but the standard calculator for stroke rates would estimate a yearly untreated stroke rate of 2.2%. If you assume aspirin does not contribute to stroke prevention in patients with AFib, which it probably doesn't, then the yearly stroke rate of 0.66% in OCEAN tells us that non-anticoagulated post-AF ablation patients have a very, very low risk of stroke. And the authors rightly point out that this could be due to ablation, which reduces AF burden, but it also could be due to selection bias in that we typically choose kind of robust patients to do AF ablation on. I know these low stroke rates are not a fluke. Stroke rates were also low in the Alone AF trial of continuation versus stopping anticoagulation. It was 0.3% in that trial per year. And in the option trial of anticoagulation versus left atrial appendage closure after AF ablation, stroke rates were 1.3 and 1.2% per year, despite these patients having a CHA2DS2-VASc score of 3.5. And of course, we also know from the subclinical AF trials, NOAA and Artesia, that short duration AFib, which is commonly seen after AF ablation, these are also associated with low annualized stroke rates. The ischemic stroke rate of the placebo arm in NOAA was only 1.1%, and in the aspirin arm of Artesia, it was 1.3%. And remember that the CHA2DS2-VASc score in those short duration subclinical AF studies was 4. So CHA2DS2-VASc 4, stroke rates per year 1.3%. Taken together, if AF ablation results in no AF burden or low burden of AF, then I think we can expect very low stroke rates. This means that we shouldn't be predicting stroke risk from a CHA2DS2-VASc score in post-ablation patients. and it calls into serious question the expert opinion recommending to continue lifelong anticoagulation after AF ablation, and I think the guidelines should be updated. More and more, I've been stopping anticoagulation after AF ablation. Note that in OCEAN, there was not extensive monitoring, just intermittent Holters. But now we have patients who have smartwatches and cardia devices, and not only do they might tell us that they don't have AFib, they can say, "Doc, my watch is telling me I'm not having any AFib either." And I think in those patients, we can seriously consider stopping anticoagulation. Finally, if stroke rates are this low off anticoagulation after ablation, the notion of placing a left atrial appendage device during or after the ablation should be seriously revisited. Now, for many reasons that I wrote about, I was not convinced by the option trial. But for any of those who were, these new data render preventive left atrial appendage occlusion at the time of AF ablation a seriously dubious practice. Why would you do it if stroke rates are this low? Just better to simply assess AF burden after AF ablation, and if it's low or non-existent, just stop the anticoagulation. You don't need a device. Okay, I went a little long today because we had an AHA review, and next week I'll have more AHA studies, and then of course we have the Thanksgiving Day break. So that's it for this week in cardiology. As always, I'm grateful that you listened. Thank you. And remember, if you like this podcast, please take the time. Give us a rating on your app. Write us a review. If you don't agree with something I say, write me an email by all means. I love these emails. Until next week, this is John Mandrola from the heart.org Medscape Cardiology.
You're listening to This Week in Cardiology from the heart.org Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.